Welcome, Dr. Gabriela Moeslein.
Thank you.
Epidemiological surgeon or surgical epidemiologist. I don't think we agreed on what exactly was the right description.
Well,
colorectal surgeon.
Colorectal surgeon.
For sure.
Yes, that's
but
right.
with a massive interest.
I bumped into hereditary disposition to cancer actually a long time ago, and never really understood why in my surgical practice in the hospital, university hospital setting I was working, patients would come with their colorectal cancer being very young, and having a very clear family pedigree for this condition with nobody paying any attention to it. And so that actually got me involved from a very clinical, surgical point of view, and I got very interested in the subject. And it was just intriguing to see that the reality, at least in a country like Germany, still is that patients from clear families come with a cancer, and they're not found before they have their cancer.
And nobody's following them, nobody's suspicious,
That's right.
Curious.
That's right. And as a surgeon, I mean, we should at least consider doing more surgery for them than is being done. The question of doing more extended surgery if patients come with a cancer in the setting of a Lynch syndrome is something that in Germany still is seeing very reluctantly. And in the Anglo-American countries, prophylactic surgery at the time when they come up with a cancer. So we're not talking about a purely prophylactic situation. Sure. We're talking about the situation when they've already shown that their colon can make a cancer. And in that situation, in other countries, it's a very clear recommendation to do extended surgery. And it's a very, very sensitive subject in Germany still.
I see. And parallels with the discussion that the senologists have about how extensive the prophylactic surgery should be in BRCA1 and 2 mutation carriers, and once you've got a cancer in a BRCA1 mutated patient, then what?
Right.
A lot of crossover there?
Well, there should be more crossover than there is because they have quite clear-cut recommendations. Unfortunately for Lynch syndrome, they're not as clear. There is no very good evidence. Actually, in Germany, we started a couple of years ago a study that was funded by the German Cancer Aid here in Germany, looking at, in a prospective randomized setting, when the patients come with a cancer in the context of a Lynch syndrome, should we do extended surgery versus oncological surgery, and follow them with yearly colonoscopies and see what is better for them. But unfortunately, it was stopped short because of a lack of recruitment. Now, looking at this in the context of the CAP study, and the results from John Burns' group, the question really is, should we give them aspirin in the context of a less extended surgery? Could this perhaps be the answer to, yes, we can live with less surgery for them? But on the other hand, I think it's very important to realize that in the CAP study, these people were on surveillance. So they were having their yearly or 2-yearly colonoscopies with polyps removed, and still went on to develop cancers, showing the potential of the Lynch syndrome and how aggressive it really is. And then, of course, it's very successful that under surveillance, the group that was on aspirin went on to develop much less or fewer cancers. Sure. But we must keep in mind that these are families under very close surveillance.
Sure. And how far do you survey within the family? What do you consider the limits of the ripple effect of the genetics?
Well, we'll always look at the first-degree family members, and then following them, again, their first-degree family members. Yep. So those are the people at a 50% risk.
And is the CAP study result now going to change your view about what you say to those families in the ripple and around the person whom you're interested in and whom you've been following?
Well, I think it's going to have a tremendous impact because, at this point, as clinicians, we are counseling the patients and telling them about their risk together with geneticists. We have a very good format here in Germany with the consortium, the German consortium. So we're looking at this interdisciplinarily and talking to the people. But, it's a huge constraint to tell someone, or family, a family sitting in front of you, telling them, you have a tremendous risk of developing colon cancer, rectal cancer, endometrial cancer, plus. And, they're much more difficult to deal with than families with polyposis, because you're imposing a tremendous cancer burden on them and a tremendous screening program. So a lot of these patients have or persons at risk or just mutation carriers have a tremendous problem with compliance. We propose yearly colonoscopies. In the European setting, we just have a paper in press looking at endometrial biopsies on a yearly basis.
Wow.
So we're looking at a tremendous screening program, and now we have something to offer. I mean, this is tremendous news. We can say, you know, yes, you have to continue screening, but we also have something for you that will, you know, certainly decrease your risk.
There's no doubt that will be motivational. That will
Yes.
sort a lot of your compliance problems. I'm sure you're right about that. It's a very exciting study, isn't it? Tell me a little bit about the possible impact in Germany. I think you said 4, 5, 6,000
Yes.
patients with lynch, and then you take the first degree relatives, and you're looking at a really quite substantial depletion of the or cut in the number of cancers. I mean, you can surely sell this to the Minister of Health.
We hope so. I mean, you know, the sad truth in Germany really is that of these, you know, about 5,000 to 6,000 people having a Lynch syndrome-associated cancer per year, you know, we should be identifying these families much more readily. And although, again, the German consortium, the HMPCC consortium, has done tremendous work, but over a period of about 10 years, we have like 4,000 mutation carriers. So we should be way beyond this stage. So yes, I really hope that this information is going to have a tremendous impact on the awareness, on the identification of these families and getting them more readily into surveillance and being identified. And a tremendous problem really is that the physicians are just not paying any attention to it. So,
well, you know, this is good news, and patients grab at good news, and I suspect
I hope so.
that they will, you know, sort of cultivate the wave of enthusiasm, and maybe you've got some good advocates who will, you know, take the charge to the Minister of Health. It's interesting that the parallels going on between the breast ovary group and the GI group, and the PARP1 inhibitors from Newcastle, like I was discussing with John, have found a niche, looks like, in BRCA1/2 mutated patients with breast cancer. But it may also be that the PARP1 inhibitors are also useful for some of the commoner breast cancers, which are pretty well genetically described now,
yes.
who don't have a classical BRCA1 or 2 mutation. Is that the sort of paradigm for the people like yourself who are studying lynch?
Well, I think so. And I mean, again, we have to, even if we've now actually found it for this result for the Lynch syndrome, we really have to keep in mind that there are maybe a lot of other cancers, like is it only Lynch, or it should be valid, the result for all of the microsatellite unstable associated cancers. And it might be even broader, looking at, you know, more sporadic cancers too. We have to see if this will have an impact on that too. But at this point, we should look actually at the microsatellite unstable cancers as general.
What about INSIGHT?
INSIGHT, yes. Well, INSIGHT is the International Society for Gastrointestinal Hereditary Tumors. It is the only international society which has a very strong combined scientific and clinical and epidemiological interest in dealing with these diseases. And again, it's not, as you see, it's not only Lynch, it is really gastrointestinal. And I think the tremendous potential of this society is several different things. At this point, one of the things that's very important to mention is it's a model for the Human Variome Project. It is looking at what to do with unclassified variants, which is a tremendously important subject. When we're looking at these families, find genetic alterations that we cannot classify at this point into pathogenic or non-pathogenic. And this is a huge international effort which is putting the data combined onto the LOVD, the Leiden Open Variant Database. And actually, the Lynch syndrome is the model for this. So this has a tremendous impact for our society, and I think as a model for a lot of other genetic diseases. So that's very important. That's one point. And the other point is, I mean, we're now dealing with, you know, the clearly identified and molecular genetically identified entities. But I mean, the subject of familial disposition is growing. And I think the potential for INSIGHT will also be to find the genetic and the phenotype vehicle of databasing in order to identify faster on an international level and dealing with these entities, which I think again they're not the 3 to 5% we're talking about today.
Double figures.
They're 15 or 20% of the dispositions, and getting that into place and sorting that out is going to be the challenge for the future.
I hope that you get a lot more funding as a result of this CAP study, and I wish you every success. Thank you very much.
Thank you so much.
Thank you.